Welcome to Medical Logistics 101, review of left lower abdominal pain. Today we'll be talking about diverticulitis. This video is for educational purposes only. It is not medical advice, does not replace a medical evaluation, and may not apply to your situation. If you have symptoms or concerns, please speak with a licensed healthcare professional. My goal is to help patients enter healthcare with a map instead of a blindfold, and to explain how clinicians think through these problems in resource-limited settings. Definition. Diverticulitis is inflammation or microperforation of a diverticulum, usually in the sigmoid colon. Two broad categories: uncomplicated, where there's just simply localized inflammation. Complicated, you have an abscess, perforation, obstruction, or a fistula present. Signs and symptoms. Left lower abdominal pain, steady kind of worsening over hours, fever, chills, nausea, decreased appetite, changes in bowel habits, usually more often constipation than diarrhea, bloating, or a sense of fullness. Pain onset is usually very different from kidney stone pain, which is usually much more often rapid onset of pain. Usually with kidney stones kind of radiates toward the groin, and you don't typically see that with diverticulitis. Very localized usually. Exam findings: left lower quadrant tenderness, guarding on palpation if it's more severe, rebound tenderness in that left lower abdomen if peritoneal irritation is involved. You can sometimes see a slightly elevated heart rate with it. Localized peritoneal signs are usually a sign that it's a more complicated infection. I always recommend a rectal exam with these patients. I want to know if there's blood in their stools for sure. Diagnostic studies: CT of the abdomen and pelvis with contrast is a test of choice. Shows inflammation, fat stranding, wall thickening, abscess if it's present. CBC I usually will get just to see if there's an elevated white count. CMP, hydration status, electrolyte abnormalities. Urinalysis, very important. I want to rule out UTIs. In kidney stones, it would be unusual for me to have a patient with a kidney stone producing pain in the left lower abdomen and not have hematuria or blood in the urine. Pregnancy test, of course, in appropriate patients. Differential diagnosis mimics kidney stones, can certainly produce similar symptoms. Pyelonephritis or UTI, again, with the kidney stones and the pyelonephritis and UTI, the UA is going to be very helpful there, of course. Gastroenteritis, small bowel obstruction. In women, I would worry about ovarian torsion, ovarian cyst, and of course, tubal pregnancy or ectopic pregnancy. Rarely, in older adults, you can see ischemic colitis. That's very serious if present, but it's not common, but it's something you have to keep in the back of your mind. Red flags: high fever, severe diffuse abdominal pain, guarding or rebound tenderness, inability to tolerate PO fluids, persistent vomiting, any sign of sepsis, fever, or tachycardia. That would be a worrisome sign, certainly, especially if it was an immunocompromised patient or an elderly patient with more of a subtle presentation. Pitfalls: assuming all left lower quadrant pain is diverticulitis. Missing kidney stones, which generally is not going to happen with the CT scan. Missing gynecologic emergencies, such as ovarian torsion. That requires an ultrasound to rule it out, not a CT. CT scan will not show ovarian torsion. Making certain patients have good follow-up if discharged home. These days, a lot of patients simply don't have a primary care provider to follow up with, so making sure that they have good follow-up, if nothing else, returning back to the ER for reevaluation. Low threshold for admission of elderly or immunocompromised patients. Disposition: if it's uncomplicated, it's often outpatient. Some debate about the use of antibiotics in the situation. I would generally prescribe oral antibiotics for these patients. Medication for nausea, of course, as needed. Opiates, you got to be careful with opiates in the situation. They can certainly worsen constipation, which would obviously complicate the situation. Clear liquid diet, advances tolerated. Again, very important, if they send them home, close follow-up in 48 to 72 hours, either with their primary care doctor if they have one and they can get in. If not, certainly can be reevaluated in the ER. Should discuss symptoms of perforation with the patient. Disposition: complicated. Patient's admission is going to be advised. IV antibiotics. Surgical consult if there's perforation or obstruction or an abscess. Follow-up: once these patients resolve and their symptoms 6 to 8 weeks, colonoscopy is very important for follow-up, just because you could have a situation where there's a malignancy that might not be seen on the CT scan, as well as to assess the extent of the diverticular disease. In closing, if this is the kind of content you find helpful, please like and subscribe. If there are topics you would like to see covered, you can email me at medicallogistics101@gmail.com. Remember, the danger isn't always what you know, but rather what you can't afford to miss. Thank you.